The combined objectives for Part 1 and 2 of this presentation are to enhance the ability of healthcare professionals to counsel patients using respiratory medicines by constructing a framework for effectively counseling patients that integrates knowledge of respiratory device features and technique with effective communication strategies, developing a systematic plan in your practice for integrating patient instruction for respiratory medicines, concisely documenting key data and results from device counseling in a patient's medical record, identifying patient-specific barriers to adherence with respiratory medicines, address these barriers with effective medication and disease-related messages, and communication behaviors. It is presumed that healthcare professionals watching these videos have a basic understanding of the treatment algorithms for asthma and chronic obstructive pulmonary disease, or COPD. We will also build on the viewer's basic training in communication strategies and experience with counseling patients in a clinical environment. Those seeking additional information on treatment are encouraged to check out the current asthma or COPD guidelines. We will begin our discussion of device technique counseling with answering the question, why is effective counseling so important? Next, we will review the challenges and limitations of respiratory device counseling using typical counseling methods. Based on these challenges, we will provide our recommended instructional framework for device counseling. Our framework is flexible enough for use at either the point of initial prescribing or at dispensing. We will demonstrate the framework in a mock patient education session. Because device technique is a skill that requires frequent reinforcement, we will discuss the frequency to monitor device technique and adapting the counseling framework for follow-up sessions. Lastly, we will provide tips to remove barriers to successfully integrating device counseling into your practice. We will begin with, why is device technique so important? Mastering the device technique with the prescribed device is an important skill that should not be left to chance. The main advantage of inhaled versus oral medicines is the delivery of therapeutic doses directly to the lung. Bypassing the systemic circulation greatly decreases the potential for serious adverse effects. All three of the main categories of inhaled medicines, beta receptor agonists, anticholinergic drugs, and corticosteroids would be poorly tolerated if given systemically on a chronic basis. The main disadvantages of inhaled medicine is that poor device technique limits drug delivery to the site of action. Drug delivery is directly related to efficacy. Even with optimal technique, only about 6 to 12% of the dose from a typical home jet nebulizer and many other respiratory devices actually reaches the lungs. So even small decreases in the absolute amount of medicine delivered are important. For example, a 5% decrease in medicine delivery because of poor technique seems small. However, this is a 30 to 50% decrease in actual medicine delivered. With some newer devices, the percentage of drug delivered can be higher. With some newer hydrofluorocarbon HFA inhalers, drug delivery can be around 50%, but this presumes optimal technique. Unfortunately, there is ample evidence that inadequate technique is extremely common. Past data indicated that 50 to 80% of patients had inadequate metered dose inhaler technique. Dry powder devices, or DPIs, appeared easier to use. It was hoped that encouraging DPI use would resolve the device technique problem. Technique does generally appear to be better with DPIs. However, some studies have shown that as many as 45% of patients still have inadequate technique with dry powdered inhalers. What are the costs and implications of poor technique? The first is poor disease control. There is now prospective data from short-term studies linking improved device technique with higher peak flow readings, decreased asthma severity, and better quality of life scores. Studies of longer duration are definitely needed, but the potential for enhancing patients' quality of life by improving device technique are huge. Some examples are increasing activity levels, improving sleep, and decreasing missed work or school days. All of these would help patients live more normal lives. COPD is generally less responsive to therapy, but there is still significant potential to improve symptom control and decrease the frequency of exacerbations. Increased healthcare costs. Care for uncontrolled asthma and COPD is expensive. Costs for urgent care visits and hospitalizations are the main drivers. It is also likely that poor device technique adds to medication costs. If the link between a patient's poor disease control and poor technique is missed, more medications are added or higher doses are used. For example, an inhaled corticosteroid could be increased from a low to a medium or high dose. Another medicine, such as a long-acting beta receptor agonist or anticholinergic agent, might be added. Potentially unnecessary changes like these increase medication costs and the risk of local adverse effects like thrush. Checking device technique before stepping up in therapy is recommended in the asthma guidelines, but checking technique is probably often overlooked. Non-adherence. Another potential implication of poor device technique is increasing non-adherence to maintenance medicines. It would be logical for patients to stop medicines that appear to them to be ineffective. There is data that instructing patients on device technique also improved their adherence. Device technique is just one factor potentially affecting adherence. We will talk about other factors that contribute to poor adherence later in this video. We have not found any data quantifying the exact cost of poor device technique, but the potential impact on patients' disease control, quality of life, and healthcare costs is vast. The next question is, why is poor device technique so common? To our knowledge, this has not been systematically studied, but the causes are likely multifactorial. Many healthcare professionals themselves are not very familiar with correct technique and differences between the devices. Data have shown that healthcare professionals, including doctors, nurses, and pharmacists, were not able to adequately demonstrate correct technique. Respiratory therapists did better, but their technique was still less than optimal. This raises several questions. Is adequate time spent on learning device technique to develop competency in the typical educational program? Once learned, is there enough practice over time to maintain that competency? Are there adequate opportunities to develop competency with newer devices as they become available? Foil packaging of actual devices discourages healthcare professionals from investigating these new devices. Lack of time and access to placebo devices are also barriers to learning correct technique with new devices. A second factor likely contributing to poor device technique is over-reliance on written instructions to instruct patients. Every prescription is dispensed with a patient package insert outlining correct device technique. If these inserts were sufficient, the problem of poor technique would not exist. What are the limitations of these inserts? First of all, the instructions may never be read. The insert may be discarded with the packaging. Patients, and likely healthcare professionals, may assume that because one has been using a device for months or even years, the patient knows how to use the device correctly. Even if read, instructions may not be understood. One study showed that none of the patients who said they understood the written instructions were actually able to demonstrate a metered dose inhaler correctly. Another study indicated that only about 30% of people could use an inhaler correctly from written instructions alone. What are possible explanations for this data? As many as 50% of adult Americans have inadequate health literacy. The average American reads at the 8th grade level. It is recommended that educational materials be written at the 6th grade level. Portions of instructions have long sentences and may be written above the patient's reading level. The print font is often small. On the plus side, there usually are pictures or pictograms which are helpful regardless of literacy level. However, pictures have limitations and may still be misinterpreted. Some steps are very difficult to communicate with picture alone. For example, how can one visualize the correct timing of actuation to inhalation from a static picture? How would one differentiate the fast breath necessary for a dry powdered inhaler from the slow inspiration required for a metered dose inhaler? Without understanding how each step contributes to drug delivery, key steps may seem unimportant. Steps like initial exhalation and breath holding may be skipped by the patient. It is relatively common for patients to be prescribed multiple devices with different technique. Metered dose inhalers and dry powdered inhalers require very different technique. Even similarly, looking devices can have a slightly different technique, so it is easy to confuse the steps between devices. Lastly, there may be patient factors such as disease severity, physical dexterity, and hand strength, and poor vision that may make one or more devices more difficult for a specific patient to use correctly. There are also barriers to device instruction in the typical practice. Community pharmacists have been surveyed regarding barriers to their providing asthma education. Several factors were identified, including time and resources to provide education and perceived level of patient interest. We will address overcoming some of these barriers later in this video.